We will be going to Dr. Bin Moller's room in just a little bit. The case that he is working on is a 69-year-old female with a history of non-cirrhotic portal hypertension due to a portal vein thrombus with cavernous formation from a presumed hypercoagulable state who is on anticoagulation. She developed acute cholangitis with an ERCP performed locally with common bile duct stone removal. There was concern for recurrent biliary stone disease and was thus referred to our hepatobiliary surgeons for cholecystectomy. Right upper quadrant ultrasound in October showed a thickened gallbladder wall with multiple stones in the gallbladder. As the patient is high risk for cholecystectomy, she was referred to IES for possible EUS-guided cholecystoduodenostomy. Let's go to the procedure room.
Welcome back from lunch. Well, to greet you is another typical challenging case at IES. So this patient is between the proverbial rock and the hard place. She is not a candidate for surgical cholecystectomy, and she's not a candidate for percutaneous cholecystostomy. She has ascites, and she has cavernous transformation. Surgeons don't want to touch her. Radiologists don't want to touch her. But she has cholecystitis, and the question is whether we can help her. So what you're looking at right now is the endoscopic view, and I just want to underscore that with the advances in scope technology, now we get really high-def views with our echo endoscope. This is a therapeutic echo endoscope that I have inserted. You can see very nicely the gastric lumen. You can see some inflammatory polyps here. I don't see any gastric varices, but she's got these nodules here and certainly some portal hypertensive gastropathy. So I'm just going to pop into the duodenum, into the bulb, and then let's switch on the EUS now. So we'll have the EUS large, and there's no need really to look at the endoscopic view anymore. We'll just focus on the EUS. And you can see immediately the cavernous transformation, right? You can see vessels all over the place. The portal vein is completely thrombosed. But you do see that there are some areas that do not light up, and that's where the bile duct is. So let's take a look here. There's no Doppler flow. Next to it, there's Doppler flow, which is also why sometimes these collaterals can compress and obstruct the bile duct. So cavernous transformation can be a cause of obstructive jaundice. So I'm just moving around. This is the head of the pancreas now. And my goal here, although we may be able to see the takeoff of the cystic duct, it's possible, but really what we want to know is what's going on with the gallbladder, and there it is. So right in the middle is a gallbladder with a very thickened wall. I bet you that's the cystic duct that you see below that, kind of a little squiggly thing, make like a comma, and that's probably the cystic duct that leads to the common bile duct. It clearly is not that dilated here, so now I'm just going to move around and look for, now you see something that is echogenic and it's creating shadowing, so it's a stone. The gallbladder, at least right here, is not very distended. So I'm just pulling back very slowly. And I think we can take, there are multiple stones in here. You can see many echogenicities. Now there's a really big one. So the question is, can I find a window to access this gallbladder for internal drainage, to place the lambs for drainage? And if we do place an axios, what size axios would we use? So as I mentioned, the indication for 15 might be a patient with large stones like this, where we can go in and perform direct lithotripsy, and we'll have a larger lumen so that bigger stones can evacuate through the lumen of the lambs. But obviously, if you're going to place a 15, you need to have a sufficiently distended gallbladder. Otherwise, a 10, in which case you need to use a pediatric gastroscope. You won't be able to get an adult gastroscope through there, or you might, but it'll be snug. and you might displace it. So right now, this is about the best I can do in terms of a window, and um, there is a little concern here. I mean, there's just something, let's say, to note. There's ascites here, and it is, you see this rim right there. I don't think that's going to be an issue, but we certainly need to place the patient on antibiotics, that's for sure. You can see the ascites there outside the wall of the duodenal bulb. I mean, to be quite honest, this is not the kind of gallbladder drainage case one is enthusiastic about doing, but this patient really has no other options. Everything else has really been explored, and she's been sent specifically to us in the hopes that there's something we can offer her. Now, what I'm going to do is just be sure that there isn't maybe a window from the stomach antrum that might be better. So let me just sort of see. And this is just where you need to have some patience and even consider moving the patient's position to see if that moves the gallbladder around. See, this is a little bit better here in terms of more fluid above that stone. The problem is the distance between the bowel wall. So if I freeze this and measure this, this is going to be more than in excess of 1 centimeter, I'm sure, right? So it's 1.6. So that is not a candidate in terms of axios with a 1 centimeter a saddle. Of course, it begs the question, and will soon be available, but could one, which would be an axios with a longer saddle. There is one with a 15 millimeter that will be available soon, but would one then consider using that? It's certainly a possibility. We do not have that available though yet. All right, so this is not an option just because of the distance away. And the only other thing I can really offer in terms of investigating or trying to identify a better window would be to move the patient. So I'm going to do that. And I don't know if we have anything going on in the other rooms, but you're welcome to switch and come back to me. And I just want to spend a little bit more time to be convinced I cannot find a better window. But if I cannot find a better window, and I've got to go with this here that you see, right? I might even go here and target that with a 19 gauge FNA needle, and I would just fill that with fluid. That's how we do the edge procedure. So we fill the remnant stomach with fluid, saline, and then it distends that remnant stomach to become basically like a pseudocyst, and then we can perform the gastrostomy. That would be then, I think, the next option here, if I can distend this gallbladder. And by the way, this is typical of a patient who has had an external drain in place. The gallbladder contracts. This is why, unfortunately, we still get a lot of these external drains where patients want them internalized, but I will tell you those can be very technically challenging because the wall becomes thickened and the gallbladder contracted, so it's going to be much more difficult to perform the cholecysto enterostomy, duodenostomy typically. We'll go right back to Rabindra in just a second. I just want to show the puncture of the gallbladder with a 19 gauge FNA needle, standard FNA needle. I could not find a better window even after changing the patient's position. We definitely don't want to overshoot. It will be a little difficult getting through this fibrotic wall, so I think a thrust will be needed to get through. But it is worth, I think, measuring this distance and locking in our thumb screw so we don't overshoot. So first of all, the wall thickness is about 0.85, so under a centimeter. So I think this is going to be okay for the axios. The 10 millimeter is what we will use in this case. And then, let me just unfreeze her. And then we'll measure the distance between the tip of the FNA needle and the opposite wall, which is just 2.2. What that means is I'm going to make sure I lock in both the sheath itself, but also I'm going to lock in the needle stroke length, the thrust length, and I'm going to lock it in at, let's say, about 3, because there's going to be a little bit of recoil when I advance. So I predict that it's going to be difficult to get through. And by the way, even though I may have more lumen here, the problem is there's stone there. It's going to be in the way. But when we use Axios later, as soon as we use cautery, that stone is going to absorb all of that electro current. So that would not be a good place to do it, to gain access. The question is whether I can fill this sufficiently to have enough room to place a 10 millimeter Axios. So let's see. If not, if I cannot distend this, then it's game over, I think. I don't think there's anything more I can do. But this is, so I'm just going to thrust in there like this. And let's see where I am. There I am. Oh, good measurement, huh? I'm right at the tip on the opposite wall, but did not go through the opposite wall. So Courtney is now going to remove the stylet. She's just pulling it out, pull it out fast. And then she's going to aspirate a little bit. And we'll send that on in for culture and sensitivity and gram stain because she does have cholecystitis. So just a little bit, not too much. That's good. Stop. So I don't want to take out all the fluid. In fact, we want to fill this now with saline. So we're going to hook up our water pump now, and hopefully you can see that. Why don't you swap just for a second, Jeremy, and you'll see here the, what? No, yes, but no, over to Courtney. Okay. Just so they can see this. So all we've done, this is what we do for the edge. Just have to tilt the camera down. Or I tilt up. I'll just tilt up. Here, see? Okay. So I don't want to move around too much. Swap it again. Swap again, please. Good. So now I'm going to step on the water pedal. I have control of that on my left side, and I'm going to just start filling it. See? Now, how well can we distend the gallbladder? That's the question. So while I'm distending, go back to Rabindra, and let's see what Rabindra is up to. Because I'm sure that Rabindra can quickly place the stent. I loved his discussion about the differential diagnosis because I agree there's some concern about a neoplastic cyst. And remember, neoplastic cysts, first of all, there's an increased risk for them in patients with chronic pancreatitis, but they can cause pancreatitis. Great. Let's just keep filling this gallbladder.